All right. I think it's thinking. Okay, I think we're live, and I'm just going to try and share this into the tribe. Oops, wrong one. So if you are watching, go ahead, drop a comment. Let us know where you're watching from. Let us know that you're seeing us and hearing us. And we'll get going in just a second. Getting this shared. Looks like there's a few of you joining us. Go ahead, drop a comment. Let us know where you're watching from. Welcome, everyone. Oops. Do that over. All right. Okay, welcome, everyone. I think we're now streaming everywhere. Go ahead, leave a comment below. Oh, great. Kathy says, yes, she can hear us. She's from Nebraska. Welcome, Kathy. Thank you for commenting. John is here from Connecticut. Wonderful. Drop us a comment. Let us know where you're watching from. It's always really cool to see where everyone is tuning in from. So welcome, everyone, to this month's, we got Scottsdale, Arizona. Thank you, Michael. Welcome, everyone, to our March TBI talk. I am here today with Dr. Perry Maynard from Integrated Brain Centers. He is in Denver, Colorado. Him and Dr. Shane Stedman are functional neurologists at Integrated Brain Centers. And today we're going to be talking all about depression after brain injury. This is, I think, a really important topic, and perhaps something that's not talked about enough and not fully understood, perhaps, in the traditional healthcare system. I have my own thoughts that we'll get into in a little bit on this. But first of all, welcome, Perry.
Thank you so much for having me. How's the weather up there? Is it snowing at all? It's about
No,
to snow
no
here.
snow. It's just not warm enough for me yet.
I agree.
I'm in Minneapolis for anyone that doesn't know where I am.
I met a lot of people from Minnesota this past weekend in Mexico, and I imagine they were trying to escape the cold weather.
Yep. Good old spring break.
Yep, exactly. But no, it's great to be here, and I think this is a great topic that I think a lot of individuals suffer from, and honestly, I think it can be one of the most debilitating and one of the most difficult things to combat after head injury, as well. And, like we might get into later too, when you start seeing all sorts of medications added on, that can sometimes complicate things. So it can be kind of a sticky subject and a hard one to deal with and for people to deal with. So I think it's a good discussion that we have.
Yeah. Well, and I'll share a little bit about my story. And when the neurologist sent me for the neuropsych exam, which if you've never had one, it's about a 4 or 5 hour exam where they just try to find all your deficits and figure out, where your problems lie. And the neuropsychologist, when I went back 2 weeks later for my results, she told me basically that I was just depressed and that we just needed to work on my mental health, and she wanted to put me on antidepressants and Ritalin. And I remember looking at her and going, well, how is this going to help my brain injury? And she's like, oh, no, we just need to fix your depression. And I was like, but I'm not really depressed. I mean, I'm a little depressed because I can't do the things I had been doing, but like, I'm not like depressed, right? Like, I mean, I feel like there's situational depression and then chronic or chronic depression. Is that the right word, Perry?
No, I think that's totally right. I think that's where you look at, there can definitely be situational depression and then, like a true physiological depression, and that is a common thing where you can see with individuals where they're like, well, if I just felt better, I wouldn't be depressed. I'm depressed because I don't feel good and I can't do those things. Versus there's individuals who are truly depressed and in the state, right, of the word, right? Their brain is depressed in activity, depressed in mood. And this is where individuals may be very sad for no reason, apathetic, so just no real emotion for other people, for themselves. Maybe the things that they used to love no longer bring them joy. You can also have individuals that just become maybe hate everything. Everything in life is miserable. They just hate everything, and to the extreme of suicidal thoughts, or unfortunately, individuals taking their lives, which is a very real thing that occurs in TBIs, and individuals who are really truly depressed from TBIs, unfortunately, is suicide. So it's kind of like that whole spectrum, and unfortunately, I think I see a lot what you talked about, where people get labeled as depressed and get thrown on medication when it's really not necessarily a true depression, but there definitely is true depression that comes with TBI. That is a mixture of everything from situational to maybe now they can't work their job, so they lack purpose, and maybe they got a divorce, or it's an invisible injury, so maybe people don't believe them. So for sure, there's psychological stressors, and there's a time and the place for counseling and therapy, but we need to recognize that sometimes people's brains just aren't working. And we'll chat about a little, I think, in a little bit probably, of circuitries that are involved, or just brains becoming fatigable. And there's actual physiological reasons where individuals it's just not working. And so you could do as much therapy as you want. It's not going to necessarily make that area work better, possibly.
Yeah. And, I think it's important for people to understand that depression that's a result of your brain injury, the depression isn't the root problem. The root problem is the brain injury. And in our traditional healthcare system, it's so unfortunate that we just get labeled as depressed or a mental health disorder, and they instantly want to give us a pill for that. Which, don't get me wrong, there are certainly situations where people truly need an antidepressant or other medication, but in a lot of cases, like in mine, I just knew I don't want an antidepressant. Like, that's going to mess up my chemical imbalance, and I'm already dealing with a brain injury, right? Like, I just kind of intuitively knew that wasn't the right solution. And they were just completely dismissing the brain injury, which was actually the root problem. And then I found functional neurology. We were able to fix some of the circuitries that I'm sure you'll discuss. And all of that depression, like I said, it was situational depression. So yeah, I feel for people. I think we're far too often labeled as just a mental health problem, when the problem is really the brain injury itself.
For sure. And I think, honestly, and this is a separate topic, I think even if you look at just depression outside of a brain injury, if you look at the chemical model of chemical imbalances, it's not, think people are starting to move away from that, and there's far more to than just an imbalance or, need more of this, right? It's really a circuitry issue. And some, there is an inflammatory piece. And we'll kind of talk about the TBI, because I think we can look at it in a few different ways, in that there can be circuitry off, which we'll talk about what that is in a second. There can be inflammation or changes to the immune system in the brain, which can lead to depression. And then there can be changes in the metabolic health of the brain. So it's just not efficient and it fatigues and it fries out quickly. So I think let's go through some of the circuitry first. I mean, if we're starting from the top and working way down, we know that a lot of depression lies in some of the executive areas of our brain. So to keep it simple, right, our frontal lobe is made up of a variety of different areas. So we have our prefrontal cortex, where you have a bunch of different areas, and you have more specifically a part of our brain called our dorsal lateral prefrontal cortex, where there's a lot of debate of how much depression comes from that area. And when you look at certain therapies will actually target to stimulate that area. More specifically, what's called transcranial magnet stimulation actually will target that dorsal lateral prefrontal cortex. But that whole prefrontal cortex has huge crosstalk with all of our limbic networks. But it's what it makes us feel emotion, appreciate music, appreciate art, be goal directed, be motivated, achieve goals and feel motivated by achieving goals, to be empathetic for individuals, and all those things, right? So that is really what makes us human. And so it makes sense that in depression, a lot of those things don't work, right? So we have to ask ourselves, why is that area not working? And so you can have a TBI, right? And that can affect that area of the brain, right? So it can affect that frontal lobe so that it's just not working very well. The other piece we have to look at is the different kind of neurochemicals, right? So we've always been talking about, serotonin or dopamine or things like epinephrine, right? So some of these neurochemicals that come up and stimulate this different area to play a role in like mood and mood regulation. Well, what's really interesting is if we look at those, the generators that produce, let's say dopamine, for example, right? They live largely in the brainstem, and most specifically the upper part of the midbrain or of the brainstem called the midbrain or the mesencephalon. And so that's where you produce a majority of your dopamine. So does it make sense that if you have a brain injury that affects that area, that it can affect those kind of pacemaker cells that help to shoot dopamine all throughout the brain to help with, let's say, reward or motivation? It could. And this is where sometimes you see individuals create maybe movement disorder. So like tremors, or they look like a Parkinson's patient, right? But it's a brain injury. And then we know that epinephrine and then serotonin are also produced in or have generators within the brainstem. And a little bit lower down in the brainstem, kind of in the pons and a little bit lower, you have more generators, once again, where these kind of shoot off. So we're seeing that anything that can affect the brainstem can affect the production of neurochemicals that then fire up into that frontal lobe. And so there can, we know with head injuries that there tends to always be a lot of issues in that brainstem, right? And it's because when there's this rotation moment, it kind of gets wrung out like a wet towel. So within that brainstem, you have all of these high-speed pathways going up, and then they're shooting up into the higher areas of the brain to really make those go. And so you can have damage within those circuits. And then if we look even farther back, we know that the cerebellum, which is your area that has to do with balance and coordination, in controlling eye movements and all those things, that has very huge projection into those areas. And that helps to kind of set the tone for those other pacemakers, right? So like cerebellum into like the pons and the midbrain to then set off all these neurochemicals upward. So if there's actually a researcher named Jeffrey Shamaman, and all of his work is around cerebellar affective disorder. So cerebellar issues and things like schizophrenia and depression and all sorts of mood disorders. So we know that the same part of our brain that has to do with balance, or your ability to rapidly alternate your hand, or to coordinate your eyes or your inner ear, plays a huge role in mood regulation. So maybe it's now important that this person with depression has balance issues, or their eyes are unstable, or they have light sensitivity. So really, we have to look at all of those circuits. And if we can find where that circuit seems to be broken and then do things to intervene in that, then you can help with kind of the actual true circuitry to work better. So in simple terms, that's the circuitry piece. Now, on the inflammatory piece, we know that in brain injuries or even in infections, anything that causes inflammation in the brain can do a few things. So one thing it can do is actually inhibit your ability to produce serotonin. So we know that high levels of inflammatory immune signals will actually take tryptophan, and instead of going into serotonin, will turn it into what's called quinolinic acid, which is actually an inflammatory byproduct. So inflammation, step one, can actually allow you to not actually produce your own serotonin, which can affect mood. Another piece is that we know that inflammation in the brain is just going to shut down circuits. So it can go into that frontal lobe or some of these other areas and just make them not work well. So you could be throwing medications, but you really need to address possibly the inflammatory piece. And then the last little piece is the metabolic aspect, in that, you know, if we look at kind of neurochemistry, and a lot of people talk about the gut, and I think the gut can play a role, and people talk about the serotonin in the gut, but when you look at brain neurochemistry is made in the brain. So the serotonin in the gut doesn't necessarily go up into the brain. Now, it does play a role in signaling to the brain via the vagus nerve and other things, but when you look at producing neurochemicals, we take amino acids from our diet, so things like tryptophan, or for serotonin, phenylalanine for dopamine, and then we have to then get them across the blood-brain barrier. In order to do that, we need B vitamins, we need appropriate blood sugar, we need appropriate iron levels, right? And all of those things allow us to actually move those into the brain to then actually make the neurochemicals. So you can have individuals who are anemic. That's going to affect their ability to make neurotransmitters. You could have ones that are maybe B vitamin issues, or they are diabetic, or they're hypoglycemic, and that is going to affect their ability to create neurotransmitters, which could lead to depression. So we can already see that it's pretty complex, and we need to figure out where does a patient fit along that area, and really get to that root cause. Because once again, if someone is anemic and they're really low iron, you could throw medication all day long, but they're not actually able to make their own. Or once again, if a circuit in the brain is not working, and that's what functional neurology really shoots to try to do, is understand the symptom of the condition, and then understand all of the neurophysiology that goes around that condition, and saying, how can we quantify and see, is that messed up? Understand all of the metabolic consequences of depression, saying, how can we quantify or test that? And then really find a way to put the patient in one of those categories and decide what treatment is necessary, because not every patient needs, methylated B vitamins. And that's what you see too, even on the functional side, is every patient gets this. If you're a functional medicine doctor, it's this supplement. If you're a funk neuro doctor, it's this eye exercise. And it could be a combination of both, and that's where we have to kind of understand the whole picture. But that's the kind of way we try to look at, especially depression after head injury, and then see what in our toolbox we have that can address that. Because once again, if it's maybe a cerebellar issue leading to a depression, then maybe we need to do more cerebellar based things, versus it's a frontal lobe issue. Maybe we need to do frontal lobe based things, or maybe we need something like transcranial magnet stem to turn that back online, versus maybe we just need to stabilize one's blood sugar or affect the inflammation, and then that plays a huge big role. So there's kind of a lot going on with it.
We have questions, Dr. Perry, from John, and I'll just read them both. The first one is, my functional neurologist is always checking my eyes. How are the eyes a window to brain function?
Yep.
And then his second question, which I think you'll piggyback, my blood sugar has been affected by the hypothalamus pituitary adrenal axis, the HPA. Does this affect other things as well?
Yeah, great question. So if you're looking at the eyes can tell you a ton, and we'll talk globally and then maybe a little bit more specifically depression wise, but your eyes are controlled by so many different areas of the brain. So your cerebellum, step one, plays a huge role in making your eye movements coordinated. What do I mean by that? Making sure that they're accurate, that they're not shaky, that they're smooth, right? That it's a coordinated movement. And then we know that a lot of eye movement centers are within the brainstem. So the generators to make the eyes actually move. So right now, checking the eyes, we can have an idea if certain parts of the cerebellum look okay, certain areas of the brainstem. If you look at the middle of your brainstem, that has to do with side to side movements, and the midbrain of the mesencephalon has to do with up and down, and then converging eye movement. So coming in and out like this. So we can get a window into that. But then to take it even higher, we know that the frontal lobe is very much associated with fast eye movements, so scanning our environment. So when we're looking at one's ability to go quickly from one target to another, we want to look at step one, how quick does that happen, or what is their reaction time? What is their latency? So from the time I flick my thumb, how long does it take for that to register for them to move? And that's what's called latency. And the faster that is, the better. In brain injuries, you see that becomes very slow. In depression, you see that becomes very slow because there's depressed activity in that frontal lobe, so everything is slow. And then we want to look at how accurate is the eye movement, because there's certain other networks that have to do with mapping out your visual environment. And then lastly, like I said, your ability to stop an eye movement on a target, there's so many different networks that have to play a role in that. And that's just quick eye movements. And then we can look at tracking, right? So there's so many different circuits, so that when I see a breakdown, let's just say someone's eyes are really slow, let's say to the left-hand side, right? So it's going from right to left, that's a little bit more that right side of the brain. And then if it's just latency, that gives me the network, versus if it's more, they're really shaky, that might be a different network. So by seeing breakdown in eye movements, we know the networks associated with it. And if you're looking at depression, where you see a lot of abnormalities in eye movements is with quick eye movements. Like I said, slow reaction time. And then there's an even more specific test called anti-saccades, which you might have done, where you have the person look opposite. So if I flick this thumb, you look at this thumb, right? So it's kind of like a go, no go, or a response inhibition. And this largely comes from that dorsolateral prefrontal cortex. So individuals with brain injuries, this is usually affected. Individuals with depression, they usually cannot do this, right? You flick up, they just want to look at whatever pops up. And so you're starting to see that that frontal lobe is not working at all in processing higher order. And so that can really give a good window into, is that area coming back online? Okay. If you look at the hypothalamus or the hippocampus and its role in the hypothalamus and things like that. Yeah. So not only can it affect blood sugar, but that whole circuit plays a huge role in circadian rhythms. So sleep wake cycles. So you may have dysregulated sleep. You may be really awake at night, super tired in the morning, maybe can't sleep. That hippocampus plays a huge role in spatial orientation. So understanding, where did I put my keys? Where did I park my car? It gets huge amounts of integration from our inner ear, because that hippocampus maps out our world. And so you can see those be affected. It also plays a role in short-term memory. So there's certain aspects of memory that come from that hippocampus as well, right? And so like the extreme of that is like Alzheimer's affects that certain aspects of that hippocampus, right? And then that hypothalamus is really everything that's automated. So once again, has a ton to do with sleep, wake cycle, hormones, and adrenal function, autonomic function. And what's really interesting is it feeds into those same brainstem networks that I was talking about. Like, so specifically, you have what's called your locus ceruleus, which is where you produce epinephrine, right? Or like adrenaline, like hormones. And so areas in that hypothalamus have huge projections to that locus ceruleus, because it has to do with arousal. It has to do with waking up and stimulating your brain. So if there's any disconnect, that's where you can see that could lead to depression or shifts in mood. So I hope that answers the question. There can be a variety of things affected by that area.
And so, Dr. Perry, I think we've covered some really amazing things. But one thing I want to touch on, if you can kind of cover this rather quickly, is so people who have been put on meds, whether it's an antidepressant or a Ritalin or, you know, other mood altering drugs. And so again, like I said, there's a time and place for them, but for some people, they'll actually hinder their recovery. And can you talk a little bit about how some of those, like SSRIs, like how they can inhibit your brain injury recovery?
Yeah, I mean, when you look at medications, what we have to remember is that although we're trying to affect one network of the brain with serotonin, it doesn't quite work that way. It goes globally. So if we're trying to affect serotonin and it's a way to interact with our prefrontal cortex and to modulate mood, well, it's also going to affect inner ear circuits and other things as well. So, I mean, most commonly where I see it with individuals is how it can sometimes affect your inner ear's ability to modulate. That's the biggest place I see some of these medications. So especially anxiety medications. So things like benzodiazepines and things like that. Once again, those are GABAergic drugs and they're trying to slow things down. But once again, you can't choose where these drugs go. You can't say just affect. I mean, some drugs are really good and are more specific, but other ones aren't as specific. If you're looking at an SSRI and it's just inhibiting the reuptake of serotonin, is not going to do it just in one pathway. It's going to do it in a variety of different pathways, you know. And so this is where, you know, and even there's other certain drugs that, you know, like I said, that affect epinephrine or maybe acetylcholine. Those can affect globally, right? So digestive function, sweating, bowel and bladder function, sexual function, erectile, right? So it doesn't just go one place, it goes everywhere. And so, I mean, like I said, going back to the inner ear, we know that the inner ear is, you know, all of those neurochemicals interact. And sometimes you just start messing with this chemical cocktail and you just start, it's hard to know sometimes what is manifestation of a medication versus what is brain injury. And then you're trying to treat possibly the side effect of a medication. So once again, like you said, it's like, there's a time for medication and medications can be wildly profound, especially if used in the right context at the right time to achieve goals. But the problem I see is far too many people are put on medications and they're never managed. You know, they're put on a benzodiazepine 3 years ago, and God knows where the primary care doctor is, whoever prescribed it. And it's like, well, what was the end goal? There should be an end goal with some of these medications, just like supplements, just like diet, just like therapies. You shouldn't be, not everyone should necessarily be there for life. And once again, there's certain things where that is indicated, but for a lot of people, they end up getting kind of stuck. And so, like I said, yes, some of these medications can affect what's called long-term potentiation or your ability to create new connections. So when you look at like benzos, or if you look at like seizure medication, which is used a ton in TBIs, and those just depress brain activity. It's really hard to make a change in someone's brain when it's being depressed. You're literally inhibiting its ability to create plasticity. And that makes it difficult. So that is the one problem sometimes in some of these medications, is it can make therapies really difficult to make changes, you know. And like I said, you see it in the inner ear, or you even see it in mood. I mean, not everyone has an appropriate response to some of these meds. They may have a paradoxical response, and that's where it goes back into genetic makeup, you know. And there's different ways people process different medications, and people don't look into that. And so you just start throwing medications, and now you're like, well, is there anxiety from this medication?
Right.
Is there depression worse from this medication because of how they process it? You know, that's what we'll try to do a lot of times as well, is look at, you know, if people are going to be on medications genetically, can they handle those medications? Can they process those medications? You know, to try to avoid some of those paradoxical responses you may see of, worsening depression and things like that. So it can affect sometimes, once again, your ability to make new connections depending on the type of drug. So that's where I think if you're with your doctor and they're prescribing medications, push them and say, what is the end goal? What are we trying to achieve? What's the timeline? What's it look like to try to titrate off of these? What are possible side effects? Sometimes getting off these medications causes even more issues. But like I said, these are important things to chat with whoever is prescribing, and just make sure that your medications are being managed and you're not just being put on medications and no one's ever checking up on them. Yeah. And then they're adding another medication. I had a call with the doctor and about seeing if she could manage the patient's medication better, because this patient just gets thrown new medications each week, psychiatric meds, pain meds. Wow. And I was like, I have no clue what's medication and what's your problem. And the doctor's reading off the list of the medications. And I was like, I have a list that's like 3 times that size. And she's like, oh, I didn't know that. And I was like, how don't you know that? And so that's the problem, because you have one doctor prescribe and no one ever talks to the other doctor. And so it's something that I always tell patients, like, press your doctor, make them give you an answer, make them really be giving you goals with it and not just giving it to you and pushing you aside.
Yeah, really great advice, Dr. Maynard. Well, Dr. Maynard, thank you so much for being here today. I think this has been a really important subject to discuss, something we haven't really covered in a while. So thank you so much for being here. And if anyone wants to get in touch with you, they can find you online at integratedbraincenters.com, and they can always schedule a free 15-minute consultation with you, correct?
That is correct.
Awesome. Well, thank you for being here, and thank you everyone for watching, and see you next month. Have a great day, everyone.